Great. I'm going to call the meeting to order, but I want to welcome a new member who is there staring at us on the screen. She's Designee from the Division of Insurance. But before I introduce you, I want to public Niels. Niels Padopoulos, an amazing member of this council for many years. He was an extraordinarily good member. He participated in conversations. He helped us a couple of the years. Wanted to be publicly recognized. I wanted in the minutes. We'll make sure that we let him know that we will miss him. We are sure he's going to have a wonderful replacement. And I want to introduce Cara Lippman. And so I'm actually going to ask you if you could unmute yourself and do a brief introduction of yourself.
Sure. Hi, thank you so much. And I'm sorry I'm remote this time. I'm at a conference in Kansas City, but it's great to meet you all. I'm actually here with Niels at the conference, and I know I have some big shoes to fill. So I joined the division in May, and I am Senior Regulatory Policy Advisor to the Commissioner, working on different regulatory projects in all the different areas of insurance.
Great. Well, we welcome you. Feel free to participate, even though it's your first meeting. That's okay. Okay. I love participation.
Thank you.
Let's see. I am going to call for a move the minutes, which were sent out, and once they have been motion to move, we will have a discussion. Motion to move.
So moved.
Thank you. Second. Second. Thank you. Any discussion on the minutes? Al.
Just a few things, please. The let's see. On the work CHIA must perform.
I'm sorry, where are you?
I'm sorry?
Where?
Oh, this follows under role of the Oversight Council. It's after 1, 2, 3, 4. It's after the 5th paragraph before election of officers. So we can take this on, we can take up the core question under the heading of financial distress and our apparent legal obligation to identify financially distressed hospitals. But I wonder whether there are any other enumerated jobs specified in the legislation that we are legally charged with doing.
So is that a question or a revision to the minutes?
Well, it's a question maybe leading to either a revision to the minutes or maybe the need to follow up. Because I remember some statutory language that seemed to enumerate specific jobs. And I'd hate to be criticized by outside groups if we're not acknowledging some of those and not doing it.
Fair. Since I don't personally, do you remember additional conversation? I'm happy to take it up in a different topic. I'm not sure I want to revise the minutes unless anybody else remembers details.
So at the last meeting, we outlined, I can envision the slide that we used to sort of that bulleted out the core responsibilities of CHIA and the various directives that are in statute. If that is something that you want to revisit at a future meeting, certainly be nice.
Sure. I think it would just be enumerating the specific obligations put on us in the law and whether we can just check off that we're doing all of them.
I think we can clarify that. I think you did have a slide that had them, and I think you were asking, I looked at this way, were there more in it? So let's take it as next. Okay. Others?
Will we take up the question of the language on total healthcare expenditures versus state health expenditures? Is that
on today's agenda?
I thought so. Thanks. I'll defer that to us.
Any other changes to the minutes? Hearing none, because you are on Zoom, we are going to do a roll call. We are required to do. I don't want to forget anybody. And you as a new member have a choice. You can abstain or you can actually approve. Your choice when I call your name. Okay, Brent,
Yes.
Eliza,
Yes.
Adriana's coming. She's not here now. Cara,
Yes.
Alan,
Sure.
David,
Yes.
Amy,
Yes.
Dana, Dana's fine, and Jean.
Yes.
Okay. So pass. Thank you, everybody. Okay, we have a wonderful agenda for today. We are going to be dealing with two meaty issues, and I hope there will be lots and lots of conversations about them. One is the issue of financing and identifying financially distressed hospitals. And the other is a deeper conversation about primary care. We're going to tee up each with having someone present some of the facts around it so that everybody around the table and newbies have an understanding of why we've got this topic on the table and what we need to talk about. So I expect everybody to participate in this. Then you may notice there are a lot more people here than there have been before, because I am totally delighted. I am thrilled. I am over the moon. I never thought this day would come. We are going to have a report on the work of the APCD that started 7 very long years ago. And it is wonderful. A percentage of our staff has been working hard on this day after day, month after month, year and year. And anybody who's ever been on a really long IT project, remember the depths of despair? When you're sure you're going to get out of the hole? We've gone through that. It's at the end. So it's important for the council members to do 2 things. One, we need to understand what this investment in time, energy, and money is all about and what we've got for it. So we're going to get a demonstration. I think it's important we know, first of all, so that we can explain it to anybody who asks what it is and what it can do for others. And also understanding what's available for analysis and what can be done and what can't be done. And then, because every good deed at this point deserves a celebration, we are going to break early so that the council members have a chance to say thank you to all of you personally and celebrate. One should always celebrate good things. So that's very good agenda for today. And we're going to start with the executive director's report with Lauren, which is both an update and a follow-up on some of the topics that came up at the last meeting.
Thank you. It's nice to see you all. So there was a request at the last council meeting to have a sort of explicit follow-up at the subsequent meetings, because we know that in discussion, there's oftentimes where we're like, okay, we'll follow up, we'll get back to you, we'll look into this. So from our running list from from the June meeting, there was a long, lengthy conversation about PBM and the new data collection requirements that CHIA has and is working to implement. So I think the update here is just that we are in the process of defining those data specifications and the specific elements that we want to collect from PBMs. We're working in parallel, we're working on the regulations, and we'll be bringing sort of the status, both the status update to the December council meeting on where we are with those PBM data specifications. But also, we really want to dive in to hear from you all. What are the use cases? What are we going to do with this data that we are expecting to sort of roll out and begin collecting in calendar year 26? The second item is just to circle back and confirm where we are with the compare care. As you may recall, we sent a letter to the legislature in August requesting the repeal of compare care, given the lack of utility, and there was sort of shared agreement that this website does not serve the purpose that it originally intended to. So that letter was sent off in August to the chairs of healthcare finance, and we've received sort of confirmation of receipt and positive feedback to the extent that they acknowledge and understand our position and where we're coming from. Another item or topic of discussion last meeting was around primary care workforce and being able to project staffing needs, demands. And this is something that we're, in light of some of those questions, many of which are being addressed through the primary care task force chaired by Director Seltz and Secretary Mahania, we're going to have a real presentation from Director Seltz today to go through sort of where the task force is and some of the work that they've done to answer some of those questions. But this is, I think, one of the things we wanted to reiterate was that the work of primary care is being shared and conducted across a number of agencies. And I think with this task force, it has been elevated to both at the legislative, on the legislative side, but also the administration side. So we'll hear from Director Seltz later in this meeting to provide an update on some of those things and to address some of the questions that were raised at the last council meeting. And finally, related to the definition of total healthcare expenditures, we made a few amendments to the language contextualizing THCE. We believe that the updated description clarifies both the purpose of THCE and also how it differs from similar calculations at the federal level. So we circulated both the language that we currently use today, that's at the top paragraph. The second paragraph is sort of the contextualization language that we plan to incorporate into our publications and our annual report, just so it's clear that when we use the word THCE, it's clear what it is, what it's not, and notes that there are other calculations of healthcare expenditures that may differ and distinguishing why and how they differ. So we appreciate all of the feedback and amendments of this language, and we'll plan on a go-forward basis, including that in the annual report and relevant publications.
I think this is a good step forward, but I feel very strongly that we need to take a second step. For example, and I have alternative language I'd like to suggest, but THC for Massachusetts may differ. Actually, it is lower. I think we need to say it is lower, intentionally lower. And we can also say either from the 2014 analysis or for an updated similar analysis that could be done for 2020, that it's X% lower, 30% lower, depending on which is the denominator. That way, reporters will be clear when they report on this, and there doesn't need to be a confusion that prevails today. And also the arguments in public. I think taking care of it, cleaning it up, and saying this as accurately as we can, and as objectively as we can, will just make life easier going forward.
Can I ask, the second sentence, the by design does not account for the financial burden, as well as does not include, I mean, a lot of that language makes it clear that the number is not as inclusive. Is that not sufficient?
No, I don't think it is, because it says may differ from, and I think we need to say is lower than, because that nails down the first point. Otherwise, it seems to potentially contradict the first point. And I think that the two should point in the same direction. A 30% or a 40% difference is a big difference.
This is a question, making sure I understand. So when it says may differ from other similar estimates, are there more than just these two?
Not really. No.
Okay.
And
not to my knowledge.
And for my sake, my understanding, this definition, I guess the context in which this definition is used would, to me, point to how specific you want to be with a number. You're putting in, we don't want to have to revisit the definition constantly if the numbers change. And so does it make sense to be so specific if this is going to be codified in some way, and then the federal numbers may change, and therefore, I look to CHIA how.
I guess I have a question. I wrote down two things that were proposals, just so we can all follow the conversation. Those who are not as deeply involved in the differences. Your first is that you wanted it to say intentionally. Does that not say that? it doesn't use that word, but by design means intentionally. Intentionally is more pejorative, to be honest.
Oh, I don't think so.
Well,
If you're concerned about that, I'm happy to,
Yeah, by design seems like. the
that's
same.
fine.
Then
But
the
in
second,
that case, I think that makes it even more useful. And we have the 2014 data that CHIA prepared, 31% difference. If for 2020, it may be different, so we might say, we might end up saying 25 to 40% below.
so the first using by design is okay. I think all of us at this point are nodding. The second one was to put the actual number in. When it is presumably not just to define the two, but when it is actually in the report, it changes all the time. Last thing we do is change definitions.
Well, I think we would use the most current, substituting one percentage for another. When we have the 2024 data.
So you're
Would be-
proposing that
would be
in the
useful.
report, which goes to policies, it says, here is the number. We put in this definition that has the number in it, is your modification, you're suggesting.
Yeah.
Other thoughts?
I would suggest a definition that is more evergreen. And if in a report, you want to make a comparison at that point in time, in the body of the report, I think you can include some of the numbers that you mentioned for that particular point in time, so that the definition itself is evergreen.
Well, if we agreed to do that as a matter of policy and refer to the most current percentage difference, I think that would be okay. But, you know, we'd have to remember to do that and make sure that the annual report next March or April has that.
So I also feel like incorporating a number could be burdensome, just practically, but just Professor, when we say other, similar, other is very broad, right? So there could be other estimates that are actually lower than what we have.
I don't believe there is any other estimate. I think we should say then, to nail that down in the interest of clarity, the THCE will be lower than that derived from the federal state health expenditures estimates.
So do we know that the federal estimates of personal health expenditures is a clearly defined term? So we know what it is. So one way to say is to keep the first sentence. Again, I still feel like other, it could be what other states are doing that we are comparing to. And then say, for example, this would be lower than the federal. So that's a little bit more clear.
Well, I don't think other states, I think we don't need to bring in other states because their methods and how they compare themselves with the federal estimate might be a matter of their statute. And I think that makes things cloudier than they need to be. I was hoping that this would be simpler and clearer so that when I talk to people, I don't need to explain every year that it's not they see total and they think total. And it's not the total by design. And I think if we preempt any concern about that by saying there is one alternative estimate.
Which is the federal.
Yeah, by the Office of the Actuary. And they come up with substantially higher estimates.
Can I add, since we're talking about how evergreen this definition is the federal definition likely to change? I mean, we were seeing a lot of change. Is it likely to change? And then we would get stuck being, our evergreen one referring to something that has changed. And so I think that that's where the may, and again, I would say that the language saying it does not fully account for financial burden of healthcare is pretty clear to your point that in terms of explaining that this is not the entirety, that this particular definition, the same.
Is what I'm hearing that the last sentence, instead of as a result, may from others, simply say this will be lower than the federal estimate?
I think that would be.
If it always is,
That
because
would
by
be,
design it is.
So
And
just
the
do away with
the federal method doesn't change, or it hasn't
But
yet.
I want to hear from everybody on this. You can live with this.
Yeah, I mean, I think an is likely is another middle ground that kind of leaves us with a place of saying it is likely to be lower, but you know, and stronger than may.
It always has been. And I can see, given the definition in statute, I think it always will be.
Always say, never say always, but that's okay. Other thoughts?
I think it's good to not have a specific number, and I agree with the folks on that. And I feel like it's fairly obvious based on, I mean, I don't have a problem with a small sort of change to it, but I think it does a pretty good job of explaining specifically what the differences are likely to be. So I think it's fairly clear when it's stated.
I think I'm hearing unanimity about not putting an actual number in. I think the debate is whether we use may, likely to be, or is. Anybody care? Alan does. I mean,
If we wish, we could say, has consistently been lower.
how does that sound to everybody? Good job. Okay. We're not going to talk about the definition again for a while, right? We're in agreement on this. Okay, I don't think I need to take a vote. I'm seeing none. Yes. This is the language that we use. Thank you. That was great. Okay, all right. Any other thing you'd like us to know?
So that is those follow-ups from the last council meeting. Maybe just I'll see if there's any that weren't included. Were there any additional follow-up items council that you're tracking?
When you said that you received a positive reply from the two chairs, was that positive they acknowledged, or positive they were sympathetic and agreement?
I would say a version of the latter. I think the sentiment was that they acknowledged and understood why we were requesting a repeal. But of course, no commitments, or they didn't affirmatively outright say, we agree with you, we're gonna go file legislation to repeal it tomorrow. But it was sort of an acknowledgement and an understanding of why we were sending in this letter.
If they don't file, would we be permitted to or inclined to file?
Unfortunately, we have not gotten that power yet as a council. So CHIA as an agency does not have the ability to file legislation.
Well, any of us could use the right of free petition in the Constitution to file.
That I'd have to consult.
Yeah.
Trust me.
So, yes, I as a public citizen, yes, you can.
No mention.
Absolutely not.
Okay, keep moving on.
Okay.
We have a full agenda.
Yes. All right. The next section I can breeze through. It just relates to legislative activity and the FY26 budget. So in July, the FY26 budget was signed. CHIA received a $34 million appropriation, which we are comfortable and satisfied with. I will note that there are some changes to the assessment structure. As you may recall, CHIA has historically been funded through an assessment on payers and providers. The new legislation expands the types of assessees that will be contributing to CHIA's budget to include PBMs, pharmaceutical manufacturers, non-hospital provider organizations. So we are working with across our sister agencies to implement some of the new provisions of the assessment. Also related to CHIA, in August, the governor signed legislation that expands the SHIELD law to protect providers and patients receiving reproductive care, including abortions, transgender care, really protecting it from out-of-state and federal investigations. The legislation also clarifies the uses and strengthens protections of sensitive data, including CHIA. So that is something that we have been following and are supportive of the changes that were made. Any questions on the legislative budget front? Nope, good work. Great. All right. In recent months, we've released a slew of new publications. Of note, our inaugural publication was titled Equity and Quality. So we looked at HEDIS and patient experience surveys to evaluate quality in primary care setting. And then we're able to stratify most of these measures by race, ethnicity, and other sociodemographic variables to look at disparities, inequities in the system. So that is one of our newer publications. We've also released our relative price report, which looks at provider price variation in the market. We issued a research brief on unmet health-related social needs, as well as releasing our quarterly hospital finance performance report with data through March 31st. On the horizon, thank you, Alex, we will be releasing our enrollment trends, which includes data through March 31, 2025. And that is notable in that it will be the first enrollment trends report that really captures the full effect of the redeterminations and changes that came of Mass Health's redetermination efforts following the end of the COVID pandemic. We will also be publishing our hospital fiscal year 24 hospital health system financial performance report. That will look at the hospital fiscal year 24 data that you know, as a spoiler alert, I think we are seeing downward trends in terms of financial performance, noting that there is variation across the market, but that's another one of our big annual reports that's coming out later this month. We also have the quarterly hospital and hospital health system year-to-date report that takes preliminary quarterly data from hospitals, and we will be updating our dashboard, that quarterly data through June 30th, 2025. We are also publishing and going live with our integrated nursing dashboard, and this is sort of an extension of our workforce efforts. We've been working closely with DPH and some of our other sister agencies to both show the demand side, which is really coming from our CHIA's workforce survey and surveying the administrators of various facilities and provider types, but we're also incorporating some of that supply side data as well. So we're excited about that, the launch of that new dashboard. And then finally, we are putting out a new research brief on medical debt. As we know, this has been a topic of great interest and growing concern in terms of the increasing levels of medical debt that we're seeing in the market. Let me pause there. A number of things in the queue. Oh, I'm sorry.
No. Just curious, when you release publications, especially the ones related to hospital financials, in addition to kind of publicly sharing via your email and website, do you do any targeted presentations to key stakeholders to make sure that they're fully informed about any kind of red flags or issues to be concerned?
It's a very timely and relevant question for this council meeting, because we're going to just sort of do a deeper dive on the process. But the short answer to your question is we do hold quarterly meetings with some of our sister agencies to do that deeper dive and review hospitals and health systems that we are sort of more acutely concerned about from their financial performance. So we do sort of mass distribution, but also hold this quarterly, what we call monitoring meeting.
Under the heading of making of the balance between data and analysis. On the PBM questionnaire survey, data collection, we talked last meeting about developing a list of questions we might hope to be able to answer in light of the data. Has that list been developed, do you know, or is it in preliminary stage?
So that is something that we are contemplating for the December meeting. Right now, we are focused on, one, getting the regulations promulgated, but two, sort of most substantively defining what data we want to collect and what those data specifications look like. We'll be holding public information sessions to solicit feedback from various stakeholders in October. But I think that the discussion around what questions we should be asking, what type of analysis we should be doing once we do collect that data is one that we hope to have with you all at the December meeting.
Well, I think that there may be a difficulty here in that it's hard sometimes to decide what data you want to collect before deciding what questions we'd like to answer with the data. And so I'd suggest it might be useful to pursue these in parallel. And maybe by circulating a list of preliminary questions by email so that we don't have to confront them for the first time, like at a December meeting. And maybe we could respond by email in any way that would be helpful.
And I think that's a great suggestion. And I think that we can take some of the discussion from the June meeting where we were sort of starting to float around different types of analysis and questions, and that we can use that as a starting point. We can articulate some specific questions and then would solicit your feedback on any additional questions and analysis we should be doing this data.
And in a similar parallel strategic sense, if we had talked last meeting about what would be the cost of updating Compare Care. And I recall a figure of about $3 million. That may be.
Yeah, I mean, I think it's some of the estimates that we were looking at included not only the IT systems updating, but also in order to really disseminate it in a meaningful way and drive users, we're talking sort of big marketing PR campaigns, which would consume a lot of that cost as well.
So in that light, under the heading of our legal obligations, the Oversight Council, to making sure that budget aligns with priorities, CHIA's priorities, I wonder whether we can move to try to preempt the possibility that the legislature will abolish Compare Care and take away the $3 million from our budget by preemptively identifying other agency priorities for which we've been underfinanced, to which this money could be shifted. So we wouldn't be at such risk of losing the money.
I hear what you're saying. I don't know that the legislature would necessarily view it as sort of like a one for one. I think we estimated the 3 million as this is what it would take to really do this right, with some question of like, is that even possible? But we weren't necessarily saying we are currently spending $3 million on this website today, and if you repeal it, then you can net that out of our budget. That was not communicated to the legislature. I think that they know that this has not. I think they have a shared understanding of the utility of the website, and I think they know that our priorities are and where we're directing resources are elsewhere in the agency. So I don't believe that it would be as simple as repealing and then reducing our budget. But I hear the notion.
Well, it's comforting that there's something we don't need to be concerned about. Although if some evil-minded person on a certain committee might say, oh, you're not doing it, we'll take away the 3 million. It might be good to say, well, no. There are these 8 things we haven't made. Just in our back pocket. I'm sure you have.
Yes.
Any other agenda items? Okay, we are now moving to a topic that is creating some conversation, which is monitoring hospital finances. And we've asked, Amazon, am I pronouncing your name correctly?
Yes.
Let us all know exactly what we're doing now.
Great. Yes. So before sort of today's discussion, we thought we would provide a little context about the data we collect, how we publish it, and give a little context into our current monitoring process. So in case anyone is not fully aware, so CHIA collects financial statements in a standardized manner from hospitals and their health systems on both a quarterly and annual basis. So the annual data is what's sort of considered their gold standard of the data that is based on audited financials. And that is due to CHIA 100 days after their fiscal year end. We typically go through a QA/QC process, and we try to put that up on the web within our dashboards within about 3 months. So that is usually our goal. And then as you heard on earlier slides, we do a more comprehensive annual report that comes out in September of each year. It will be coming out next week on fiscal year 2024. So that is the key annual data that we use. And then on a quarterly basis, we collect what would be considered preliminary unaudited data. It includes cumulative year-to-date data for all of the hospitals and their health systems. And that data is typically published within 90 days of quarter end. So sort of turned around each quarter. So with that, we put out 3 sort of different publications that exist. So there are interactive dashboards on our website, one that is based on the annual data and one that is based on the preliminary year-to-date data. We also, as mentioned, have an annual report that comes out every year. And then there are comprehensive data books, which include all of the data for those that like to get into the weeds on the numbers themselves. So this comes out, it is published on our website on a regular basis, and it is updated regularly with the most recent data we have available. And then last, which was also already mentioned, is we coordinate and work closely with our other state agencies to monitor hospitals with financial concerns or things of note that have happened in the data in recent changes. So the next couple slides just depict a couple of, I know they're small, so I apologize for that, of our dashboard, just to give a sense of some of the data that is out there available on a regular basis. So this slide depicts both total, so they're sort of net and then operating margins for all of the hospitals in the state. You are able to sort of, it's sorted from lowest to highest, and you're able to filter by system, by region, by cohort, things of that nature. So that allows some comparison, sort of easily accessible and readily updated. And then the next one that is depicted is a 5-year trend for each of the systems, as well as their hospitals and physician groups that we collect data from. And this includes both profitability information, so again, the margins. It also looks at their liquidity position, solvency, and their net assets over time. It also includes a few notes on payer mix by hospital, their relative price. So it tries to bring in different data sources so that you're able to view changes over time for the hospitals. And then last but not least is another view of the margins for comparisons, which goes really by hospital. And you were able to compare the hospital over time to the statewide performance as well as their hospital cohort performance. So academic medical centers are compared to each other, community hospitals are compared to each other, et cetera. That is sort of to give a little context on the data that we have out there now and how we present it for discussion.
And then we take this and meet with people. This gets to, how do people know it's out there? How do people know where to look?
So we have the public dashboards, which Liz has provided screenshots and just a flavor of some of the information that you can find. But in addition, so all of the financial metrics are for hospitals and health systems are on CHIA's dashboard. We understand that's a lot of data, a lot of information to sort through. So we sort of go a step further and have quarterly meetings with our sister agencies, including UHHS, Mass Health, DPH, HBC, and go through, do sort of a deeper dive on hospitals or health systems that have more concerning trends. If there's been a recent change in the most recent quarter, we'll note that. But that's really to provide that double click into the more concerning hospitals and health systems.
We had this topic on the agenda because the question is, how much information we give and is it really useful? And are people aware of it and how is it being used? So thoughts, Alan, just want to.
And I think also whether we're complying with the statute. Because the statutory language says the center shall publish annual reports establishing a continuous program of investigations and study of financial trends in the acute hospital industry. The reports shall include an identification and examination of hospitals that the center considers to be in financial distress. And I don't believe we've done that, but the law says we have to. And I don't think we have any choice in that, unless I'm misunderstanding something.
People.
I think that the concern that's been expressed in this, I think in this room, or certainly is that, as you know better than anyone, this is incredibly complicated number. I mean, the data is incredibly complicated. There's so many variables. And what I think we obviously have to take seriously, what is the impact of our doing so in a really public way on the ability of that hospital to pull itself out of that position.
Mm-hmm.
And so I think that's why I hope this conversation can be about sort of how do we do this in a responsible way that doesn't, and or could we, point to the dashboards and say this very clearly shows who is distressed in a way that does not bring attention to a hospital that is actually detrimental. Because our responsibility is to not be having a negative impact on hospitals that are currently struggling.
Can I take a step back and make sure I understand? I think that what the statute says, we have to identify hospitals under distress. I mean, if you look at this data, I mean, yes, if you could figure out who's under distress, if you know that they're, well, the criteria that are all here. Then the question is, is that obligation met by going to the people that you just talked about? In other words, CHIA goes to all the people that have legal responsibility department, public health. These are the hospitals we're worried about. You go to the HBC. These are the hospitals. You go to Medicaid, probably say these are hospitals. I mean, I don't know, who all the people are in government that get. You're not. Maybe A&F gets it. I don't know. Is that going on, and into what level? And does that help us meet at least that first pass?
I think there are two things involved.
Okay, can I get the question answered first? Then I'll go right back to the promise. So for those who are in it.
Yeah, so I agree completely. I think that's the obligation being met, is that you're producing the dashboard and then having the meetings and doing the follow-up. Because I think, to Eliza's point, there's a very careful balance here between monitoring and causing unnecessary public distress about it. And so I think that the meetings with the agencies who are responsible and have oversight there meets our obligation as a council.
So if you could help for those of us that aren't in your world all the time, what are the agencies that you go and talk to? And what is their responsibility?
So I think Lauren had just named
Right.
them. It's
So it's
CHIA, UHHS.
I'm sorry, hold on. So we are CHIA. CHIA goes to.
Goes to.
CHIA goes to you.
To UHHS, Mass Health, DPH, and HBC.
See, and Mass Health. Okay. And they are the people that have responsibility. The agencies that have responsibility for the financial health of the hospitals. Is that
I
what
would
we're
say
saying?
that really nobody has responsibility.
Well, that
was gonna
actually is a good
say.
point. Yeah, you're right. Nobody has.
Others.
That was one of the flaws we've discovered. Okay, got it. Okay, but in theory, these are the four agencies that have to know. Okay, now, go.
I think the legislature and a number of political and other people have a kind of approach avoidance on this topic. They wanted information. We established the 404s for quarterly financial reports for advance warning. There was the 90-day notice before you shall service or hospital, all of which are essentially ignored. We have the DPH hearing process that services or the hospital is found to be essential. Nothing happens and they close. I think the law is pretty clear because the paragraph involved says the center shall publish annual reports. The reports shall include an identification. So I think legally the position is clear. On the substantive matter of unintentionally undermining hospitals, everybody who's a doctor at those hospitals or a supplier or does business with those hospitals or a potential lender or current creditor knows which ones are in trouble. The only people who don't know are the people who are going to be denied care when the maternity or the inpatient psych or inpatient rehab or the entire hospital closes. They're denied advance information and time to organize, to help put pressure on the legislature or other parties, some payers perhaps, to help protect the hospital and stabilize its finances before it's flushed down the toilet. And if it's a needed hospital, we had 140 hospitals in the state when President Kennedy was elected. Depending on how you count, we're in the upper 50s now. And I think this is a matter of some concern. I think the DPH public hearing process has become a political and clinical and ethical embarrassment where people feel, well, they had the hearing and they got place closed anyway. Stewart is another wonderful example. I think that if we publish this information, as the language says we shall do, identifying and examining hospitals that we consider to be in financial distress, will move forward in time. The public discussion, citizens, patients, voters, served by a given hospital or a given service, in time for them potentially to organize and help preserve a needed hospital before everybody ends up in Berkshire Medical Center, Bay State, UMass Memorial, and Mass General Brigham.
I've given this a lot of thought, and thank you, Dr. Sager, for bringing this up. When HPC was first established, they had a trust fund that they gave to us to help administer and give grants to community hospitals. They call it the Distressed Hospital Trust Fund. And there was a kind of a blunt criteria that was in there about who was eligible. It was basically community hospitals, nonprofit, and you had to have relative price below the statewide median. We had a bunch of money to give out to hospitals, and the hospitals were really interested in getting those grant funds. But to a one, they told me, please don't call me a distressed hospital. And I said, why do you care what the HPC says? And they said, it matters what government says. Your government agency, this calculation that's in this law is not a perfect way of saying we're distressed, but you're going to call us distressed. And that it did matter for things like recruitment of clinicians, that people will Google our name, our hospital, and this government agency is saying we're distressed. That well-meaning media members will pick up and write a story that says our local hospital is distressed because you had made this little calculation that says we're distressed. So we ended up changing the name of what we gave the grants. We called it the Community Hospital Acceleration, Revitalization, and Transformation Chart. They like that a lot better. But I still think about this, and I think about causing unintended harm. I mean, you talked about a scenario where there could be a really positive outcome, and I still think about those areas where those scenarios where there could be unintended harm. And I think we could come up with some type of formula or some type of way of defining what financially distressed is, but it's still us making a bunch of judgment calls. How much do you weigh the last 2 quarters of performance compared to the last 5 years of performance. That's a judgment call. How much do you weigh number of days of cash on hand versus their debt liability ratio? That's a judgment call. How much do you weigh their performance versus their cohort versus a statewide performance? That's a judgment call. All of these are judgment calls. And you could say, okay, if you do 3 out of 5 judgment calls, you're financially distressed. Okay, why not 4 out of 5? Why not 2 out of 5? That's a judgment call. And so what we're left with at the end of the day is gonna be an imperfect list. And we're gonna put that out there, and there are gonna be consequences from that. What we talk about as state agencies, when we look at, oh, we actually know what's going on with this hospital. We know that they went through bankruptcy 2 years ago, they're cleaning up their balance sheet, this is what's going on. We actually think they are trending upward. We can look at this one and say, oh, they actually had a fire. That's why their utilization is down. You won't see that in the numbers, but we know it. We know that context. We might know and say, they just went through a huge leadership change. That's maybe concerning. That's a destabilizing impact. We want to keep an eye on them. But that's context that you'll never see in those numbers. And it could go both ways. So I just worry that whatever we decide and make our decision about labeling someone financially distressed and publicly putting state government's name on that is going to be imperfect, and that could have consequences we don't understand. And it could be used for things that we don't know. So that's why I would just urge us to be cautious.
I'm curious if these conversations with sister agencies about hospitals that you're monitoring include leadership from the hospitals to better understand the context that Director Seltz mentioned, and if it is an opportunity to try to marshal resources to support these hospitals. I'm thinking of an example of Haywood Hospital, which emerged from bankruptcy. And my understanding is that the community really rallied behind that hospital. Patients continued to seek care at the hospital, even though they had alternatives, albeit much farther away, and providers stayed on wanting to help the hospital emerge from bankruptcy. They are by no means out of, challenging times, but they have emerged from bankruptcy, and it was very public that they were in bankruptcy. And I think there is a lot of nuance. The context is important, but rather than kind of blacklisting or calling a hospital distressed, is there a way to reframe it as an opportunity to really rally the resources necessary to stabilize these hospitals?
Well, David, as always, you've spoken comprehensively in a balanced and grounded way. And I think David's remarks, and Ami's yours, point to the need to weigh the risks and the gains of both approaches. On one matter, I think that any doctor who's thinking about affiliating with a new hospital is going to check out its finances and its stability. Increasingly, nurses do that. So I don't think that people are going to be deterred from. I think the risk of further destabilization from appearing on our list is actually very low. And this is something I've had discussions about. I don't want to pull rank because I can't do that, but I can certainly pull age because I've been looking at this for 45, 50 years and having a number of discussions with people about this. On the judgment call matter, if it were a matter of judgment and weighting ad hoc, I would agree with you completely. There are financial predictive models, and I've sent the Cleverly model to you, describing how accurate it is. I've got a model that predicts closings across 1,200 hospitals, 52 cities, decade by decade. It's about 85% accurate, even going out 20 years. But I think the largest question is, everybody's talking about hospitals in trouble, but nobody's accountable for doing much about it. You are to a degree. Public health, no, they're not. Mass health to a degree. We could see where the money goes under the hundreds of millions of dollars the legislature just made available, whether that's actually going to need or politics unimaginably or other factors. But if we had a declaration that these hospitals are in distress, somebody might say, well, you know, the closing of this place might be a bad idea and something needs to be done. So I think on balance, that force would tip toward protecting needed hospitals before everyone's being served in a major teaching hospital, plus Nantucket and Martha's Vineyard.
I think, you know, the way I think about it is that about looking at sort of CHIA's purpose and its function. And I think the way that it was sort of designed was to be sort of an unbiased provider of data and of, you know, to collect all the information and present it so that policymakers and legislators and executives and all sorts of people can make the right sort of decisions in order to affect and do the right thing. And I think we have to be very careful about doing something that, like making the sort of arbitrary sort of calls about making an arbitrary call about what is distressed strikes me as something of sort of putting finger on the scale and trying to, and I think it might sort of at some level diminish sort of CHIA's sort of well-earned reputation as sort of being unbiased and just a provider of the information for people who then use that to make the policy and legislate and that type of thing.
Topic I would really like to hear from everybody on, particularly not those that work in particular agencies.
I agree with David's point. I think a lot of this came about, if I remember correctly, as we were digesting the steward crisis. Because if this information had been presented, imagine if we color code by system, steward would have looked so prominent and striking that would have called for immediate action. I think that's part of how it came about. And then we realized that we really needed transparency. You know, we needed an organized way of accessing information so that the right people can make decisions. But transparency is not exactly the same as having sensitive information take on a public life. So I think there's a fine line between the two. So I do feel that we should be careful about, you know, who is in what position needs this information and how are they going to have access to the information versus making the public sort of consume information in ways that we're not able to control. So I do agree with the sensitivity that we need to have here.
I also agree with David's.
When I was teaching, I go.
I also agree with David's assessment, and I think that some of the dashboards do a nice job of doing this in a balanced way by offering the cohort averages, by offering the industry-wide averages for all of the different metrics. The challenge with models is that everyone can come up with their own model, and some might work better in some circumstances than others. Some might work better in some contexts than others. How do the models account for what AI is going to mean for healthcare in the coming 10 years, right? Like the models there's no input for that right now. I think that it would be troubling for CHIA to put itself in the position of trying to read tea leaves by picking the best model when there's going to be empirical debate about what models are most appropriate in what contexts.
Any other thoughts?
The law says we have to do it.
Well, I guess one of the suggestions that I would have is you can interpret it in several different ways, and I've heard a couple people interpret it differently. Ask a general counsel next time. Yes.
I hadn't heard any disagreement about the legal language.
I believe I heard someone say that I felt that was, I think you did, that from their understanding it was met by a meeting with the 4 agencies. And
so, I mean, this was an issue that came up in the auditor's report, and that is published, our response is public, the auditor's sort of interpretation. And our position is that we are carrying out the letter of the law by identifying our version of identifying distressed hospitals. If you flip back to slide 13, you could make the argument that you take however one wants to define distressed. You could take the top 5, you take the top 4 in that. That is identifying hospitals with really concerning margins. The law does not say you need to draft up a 4-cornered list and post it on the website. So we believe we're fulfilling the letter of the law through not only our dashboards, which we believe speak for themselves in terms of which hospitals and systems are distressed, but also through the additional step that we take in providing a deeper dive review with our sister agencies.
So the data that is provided, somebody other than actually getting review, but they would figure it out. And that actually is pretty secret.
I think politically, a lot of people would not like to see this information come public because it might press them to act and take some accountability for the shape of hospital care instead of the non-existent free market and the largely on the sidelines government not taking accountability for identifying and preserving needed emergency room or maternity or inpatient capacity. So I think we're missing an opportunity. Clearly, the sentiment around the table is nearly unanimous. But I disagree about, I don't think we're identifying and examining hospitals that we consider at financial distress, because we never use the phrase financial distress. So I think that's actually not fully accurate at all to say that we're in compliance. And I doubt if any court would agree. I'm not planning on litigating. By the way, I should mention as a disclaimer, I am appointed and have been appointed by the state auditor, but I've never spoken with her or anyone else in state government about any of these matters. And I'm only speaking because this is what I think.
Yeah, and it is appreciated. And I mean that sincerely. We're having a good conversation, and that's the purpose of having council. I am going to move the agenda, however, because I think you're right. You read the rule.
It wasn't hard.
But it's a good conversation. And it may come back. So we shall see. I'm going to close down for now and thank everybody. And thank you for all participating. And I know it's awful to be called on, but I really do think you're here for a reason. And you have a lot to add to the conversation, and it is appreciated. So we are going to move on to another incredibly important topic, which is primary care. And we're going to not give you as much time as you might have wanted, David, but
How much time do I have?
you've got, let me think. I'm going to give you till 10 minutes.
Sure, okay.
We go off on interesting tangents, but
Yeah,
I'm not going to let the APC not have the attention that it deserves, because this happens to them
absolutely.
quarter after quarter after quarter.
7 years worth of work. I will be quick.
And we can revise, we can also have,
Yeah.
I'm sure this will come up again.
I think all of the council members are well aware of the crisis of primary care in our Commonwealth. The governor has made this a top priority. She talked about it at her State of the Commonwealth. We released a report, you can go ahead. Earlier this year, we called it the dire diagnosis, the decline health of primary care. And we really, tried to pull all of the different data from a bunch of different sources to really kind of create this diagnosis of the problem. And if you move to the next slide, we really, tried to think about the workforce challenges, the fact that we have one of the lowest rates of physicians going into primary care in Massachusetts. We have an aging primary care workforce. Our state, while we have a high number of primary care physicians per capita, we actually have the lowest share of primary care, one of the lowest shares of primary care physicians, because we have a lot more specialists in Massachusetts than other states. And the amount of money that we're spending on primary care as a share of total healthcare expenditures is actually going down. and is around 7% of total healthcare expenditures going to primary care. That you can see on this next slide here. This is just showing the share that we spend on primary care and the share that we spend on all other medical services over a number of years. You can see the very slow growth in primary care and the almost double the growth in all other medical services, resulting in that declining share of the dollars going into primary care. This work has been really aided by CHIA. CHIA has really taken on a leadership position in having really great data on the share of primary care spending, and being able to do this and calculate this and create a lot of great primary care dashboards. So here again is that same type of calculation, and breaking down by different types of market segments. And being able to track that. We can track behavioral health spending, we can track primary care spending. All of this is coming from aggregated reporting from the payers that CHIA collects, and it is able to compile, and it's really created an incredible data foundation. As part of the legislation that passed at the beginning of this year, it also established a 25-member new task force to really come up with some solutions to this issue. So having kind of issued this report to be like, here is all of the problems that we see in primary care. We said, okay, let's not dwell on the problems anymore. Let's start talking about solutions. And so this primary care task force has been meeting, you can move to the next slide. A 25-member task force, as I said, really to make policy recommendations to the legislature, stabilizing and strengthening, increasing the recruitment and retention in the primary care workforce, and increasing the financial investment in and patient access to primary care across the Commonwealth. And we have a number of very specific deliverables, if you skip 2 slides ahead, that the task force is charged with in the statute. All of which kind of work together and touch on both increasing the investment in primary care, changing the way we pay for primary care, changing the way that we deliver primary care and supporting team-based primary care, and kind of relieving the administrative burden that we put on primary care. And the stat that I always use is an estimate of for every 1 hour of clinical time, there's 2 hours of administrative work that primary care physicians are doing right now. How do we fix and make primary care something that people want to go into and feel rewarded in doing so? Our first task was defining primary care services and codes. Why do we want to do this? Because we want to be able to measure primary care spending and be able to track that. And if we were going to, and to add to that, to be able to set targets for increasing the proportion of primary care spending. Well, we were in a great position to do this because CHIA is already doing this. And so we've met as a task force many times. And just this morning, we confirmed and the task force approved deliverable number 1. And why don't you skip 2 slides? And this is what the task force agreed to. We said, CHIA has already developed and implemented a highly credible and robust process for defining and measuring primary care spending, and that we recommend that we rely on CHIA's technical expertise and experience to continue this foundational work. If you go to the next slide, the recommendation continues, but the legislature should codify this role as CHIA as the agency responsible for defining, measuring, and reporting, that this should be a transparent methodology that is on the website and with a designated list of codes, that CHIA should be informed by the methodologies in other states and should include a comparison of our methodology to alternative approaches. That there should be an annual process for review and revising, which there is already today. We also included on the next slide a concept of a new primary care technical advisory body, which would provide ongoing technical advisement and input to CHIA on any technical revisions that may be necessary from year to year. That the CHIA would do annual reporting, breaking down primary care spending, by all these different types of insurance type, by member, by age group, by payer, which CHIA already is doing. And that we would be able to use this CHIA measurement for the purposes of a spending target. So first of all, thank you, CHIA. We got this deliverable passed and approved by the task force today. And why is this a great foundational and then such an important foundational piece for some of the later recommendations to come? It's important because many other states, and including as they're charged as a task force, have set future targets for increasing the proportion of spend on primary care. So I said earlier, we spend about 7 cents of the dollar on primary care. Many other states have said, let's make and set a goal as a state to try to get to 10%, 10 cents on the dollar, or 12 cents on the dollar, or 15 cents on the dollar over a number of years. Let's measure and track. And that will create a complete rebalancing of our healthcare system that really emphasizes and puts primary care as a valued part of our system. So if you move forward a few, 1, 2, 3 slides. I know I'm out of time. Okay.
No, that's okay. You're doing great.
So this is some of the primary care spending targets that are currently in some of the legislation that's currently before the legislature. And you can see, Senator Friedman's bill proposes to try to get to 12% by 2029. Representative Haggerty's bill, 15% by 2029. Representative Schwartz by 12% by 2028. So all of this work about trying to, increase the proportion of spend on primary care builds off of how are we defining, measuring, and tracking primary care. One more slide, and then I'll shut up. So I want to just highlight one state that is doing this. California set a pretty aggressive target, 15% by 2034, and some incremental targets in between. One of the things that this task force is going to continue to think about is what is the accountability for setting a target? Do we measure on a plan by plan basis? If plans and providers don't meet certain incremental targets, are there consequences? What would that look like? And then as we are increasing the dollars going into primary care, we also want to think about, do we want to change the way that we're paying for primary care? Moving towards more capitated models, moving towards perhaps PMPMs that would be able to free up the kind of the flow of money, get off of fee for service a little bit, and be able to help support primary care providers doing team-based care, doing things, being able to have more supports that enable them to refocus on clinical care. We have 2 work groups that we've set up for the overall task force. One is on data and research, and the other one is on workforce. And that workforce one is really going to be thinking about, I think, to the staffing questions that were earlier, what do we need 5-10 years from now in terms of this workforce? What are the policies we're going to need to put in place to get to that 5-10 year window? And how do we actually change the job of primary care such that people are rewarded, want to stay in this job, and that there is a pipeline of people coming in behind them who want to serve in this field. So thank you. I'm excited to give you guys some updates as this work continues. We had a little bit of a milestone today, but I think the hard work is really yet to come.
Thank you. That was a speed meeting. Thank you. But I think you really covered what you're doing and where it's going in some detail. But I do want to make sure, and the reason I said 10 is so we have a couple minutes to talk. So, because we talked a lot about primary care last meeting.
Can you say a little bit more? There are a lot of ways you could increase the percent that you spend on primary care. You could increase volume, or you could increase reimbursement, you could lower specialty volume, you could lower specialty reimbursement. How are you guys thinking about the combination of those factors?
Yeah, I think states that have done this work before, I think that's part of the attractiveness is that you can have some flexibility in thinking about that. How do you get more people connected to primary care, right? That's kind of both a volume and an access way of getting into primary care. And as you said, maybe there's a restraint on the growth on all the other healthcare spending. One of the principles that our group also talked about is if we're growing primary care spend, the task force also said that shouldn't add on to total healthcare expenditure growth. So that they do think that this should be kind of within the pie of growing healthcare growth. So I think you've kind of mentioned some of the ways that you could do that.
Yeah, I'm thinking like if I was a payer, the easiest way to do this is just say I'm gonna pay my PCPs 20% more and not do anything else.
That's one way. So some of the other states that have done this, the plans have done more kind of like non-claims payments and said, this is for primary care, we're giving you kind of a bonus payment. You do that with this what you will. And so that's maybe less like increasing the payment rates for the fee for service. So there's some flexibility. I do think the task force is gonna wanna talk about that and say like, if we're saying we wanna put more money into primary care, we should also be directive about where we want that to go.
So Rhode Island did this some decades ago because they have a health insurance commissioner who told United Health and Blue Cross, you're going from 6% to 11%. And not on fees, but on doing other stuff. Rhode Island primary care is a disaster. Probably not because of that, but despite that. So would the percentages apply only to privately insured patients? Or would they, in the legislation, do you recall? Or do they also apply to Mass Health and Medicare and Medicare Advantage?
Yeah, the legislation does apply to each of those different market segments. And so that's the answer to that point. And I guess my position on this is that the spending target is not the answer to fix primary care. It is in some ways just a symbol and about our values and saying like, we need to rebalance this system and put more money into this part of the system. But fixing primary care is gonna be around changing the payment methodology. It's gonna be around changing the administrative burden. It's gonna be around fixing the delivery of care, having team-based care. I think that's gonna be more of the hard work that's gonna really help primary care. I've had in conversations with primary care providers, some of them have told me like, you don't need to pay me more, but if you could just fix prior authorization, I'd be super happy. So it's gonna require kind of a whole constellation of solutions. I don't think there's just one that's gonna do it. Yeah.
If we want more primary care, we have two choices. Apart from things like taking away most of the paperwork. We can draft them, like we did during the Second World War. 40% of doctors got shot at low pay. Or we can pay them more. But I don't think the kind of incremental progress we're talking about is going to pay visible dividends because you do so much better outside primary care. Unless more people are recruited into medical school who have more of who have a very different outlook. But the medical schools and the teaching hospitals are not inclined to do that for partly legitimate and partly not legitimate reasons of their own. But paying them $400,000 a year, dropping panel size to 1,000, plus 30% fringe benefits, we would need 7,000 primaries. So it translates into 1.5, 1.8 billion, which is a tiny percentage of healthcare spending. Of course, there'd be a need for support, but I think I would urge considering more aggressive steps that are commensurate with the severity of the problem and with the very diagnoses you've mentioned. What's politically entertainable today is almost guaranteed not to make the kind of difference that I think we would all around this table agree is desirable. And that's not a hostile suggestion.
No, I will share with you, the members of this task force are very much urging very strong action. So your comments are well taken.
Yes, obviously the primary care crisis impacts all of us, but there are segments of the population that are disproportionately impacted. Just curious if equity has been kind of a part of the task force's discussion, how to incorporate those considerations in terms of priorities and special populations to focus on.
Yes, absolutely. Yeah, that's definitely come up. One, in terms of how we're thinking about measurement and stratification, but also I think more specifically in the workforce work group, and as we're thinking about pipeline incentives and tracking that, and also, you know, thinking about some of the things we've been thinking about in terms of family medicine residencies and how we might be able to source those in community health centers in different places of the Commonwealth. So large, yes.
I hate to cut
Yep.
the conversation off ever. This can come back. The first thing I think we all took from the presentation was how important she is and how great it is that we already have this and we have the data and information and support that all the people that are on the committee need to make decisions moving forward. And I am absolutely sure this will not be the last conversation that we will have. So we're going to turn it over. I'm sorry you got cut a little bit low, but we're going to start with an overview from Mike. Where are you? It's almost since the beginning, and
Yes.
yeah,
It's been-
you remember
yeah,
the values of
13
despair.
So I just want to start for the new council members, especially what the APCD is. The APCD is our all-payer claims database. It is our largest data asset that we collect. It is healthcare data from payers, specifically 52 payers send us data every month. Medical claims, pharmacy claims, dental claims, member eligibility, provider data. It is a very rich data asset. It is also large and very hard to use. And so there's three major issues that we found for ourselves and for our sister agencies and our researchers that try to use this data. There's a technical complexity. It really is large. 1 year of data is about 1,000 times larger than the hospital data that we have. And so we can't even transmit the data to customers electronically. It's too big. It would take weeks to transmit the data. So we've got to put it on encrypted hard drives and give it to people like it's the 90s. And then when they get the data, they have to build their own IT infrastructure to stand it up and use it. They spend money on servers or on cloud resources now. And then they need expertise to load the data into a usable way. Health Policy Commission is an example of an agency that does this, and it's expensive. It's also very time consuming. You have to do it every year to add more data, or even more often if you want the data more often. It's complex to use claims data. Claims data is raw data designed for reimbursement of services rendered. It's not designed to study public health. And so using claims data in a way that can answer some of these questions requires a lot of data preparation. Just something as simple as researching statins. You have to know what all the generics are in order to do that. And that's time consuming work. There's a lot of data preparation that goes into that. And then once you load it all and you do all the prep work, you need someone with pretty robust data science skills to actually be able to use the data. And so in 2018, we got together and decided that we were going to try to invest in a better version of the APCD, which we call the Enhanced APCD or EAPCD. We entered into a 5-year contract with a vendor to host an online version of the system, to design a data warehouse that was easy to use for users, and to provide an interface by way of a business intelligence tool for us to use. That 5-year, it took most of the 5 years to actually construct it. The vendor needed more assistance in building it than perhaps we all hoped. We jointly developed it really over the course of this project. It was 2019 when the project started. They were acquired within a month of us doing the deal. By the end of the 5-year deal, they had been sold. And we also had a global pandemic during the development project. So there are a lot of influences in why the project was challenging, but we learned a lot and we built a system that we liked. We were very happy with the end result, with the exception that why don't we go to the next slide? the vendor wanted a 3x increase in price after 5 years to renew, which was gonna take the system into a very cost prohibitive situation. Assuming we were able to find the budget to really make up that difference, we had to really ask ourselves whether the solution was worth the amount of money that we were gonna end up paying for it. So that was a big consideration. The design, it was 2019 state of technology, pre-cloud in a lot of ways for some of this technology, and it didn't perform the way we needed to in terms of the speed that analysts could get at answers. And it also they had to take the system down 4 to 6 weeks per quarter to update the data, which in some ways it's almost silly when you think about how long they were pulling it down, but that was because they did not anticipate the amount of data manipulation that they were going to have to do. And so the system that they purchased for us was not up to the task of what we ended up actually implementing. So we embarked on a discussion, this is also right after Lauren started, to figure out what to do next here. The good news is we had a great design. We really liked the system and poured a lot of our knowledge and our vendors' knowledge into the solution that we had. And so we proposed a project. We thought we could replicate what the vendor had built in a 14-month effort using the funding that we saved by not renewing the contract. We could employ best-in-class cloud technologies this time when we did it, which would improve the speed. We could redesign the quarterly process so that we wouldn't have this 4 to 6 week downtime. We really thought we could take everything that we had invested and leverage it and build a solution that would carry us forward, but also one that, felt economically supportable in the future. And so, go ahead. So now we are 14 months later. Many of you weren't in the council 14 months ago, but if you were, I came to this meeting.
I know, and I want to say it was a leap of faith because you, Lauren, and you, Mike, and the team, it was a risk, and you said we should take it.
It was a risk that Lauren had to support. It was a risk for me to say we could do it. It was a risk for my team back there, which assured me that they could do it in the time. And I came to this meeting in March last year to pitch this. So we're at the end. We're at the end of something that really started in 2018. And there are plenty of people behind me that were here the entire time for this project. Ashley is going to do a demo in a few minutes, who was part of the project from the beginning. So now here we are at the end of this project. The vendor wanted $5 million. It was going to be that plus more money for some of the licenses that we needed. We are now spending about $1.2 million to maintain this in perpetuity. The system's down for 4 to 6 weeks. We engineered it so it'd be down for a single day instead, which is, part of the headline here is we're not going to have a system down anymore, even as we update the data every quarter. The database technology we're using is even faster than we had hoped. And so now that we're realized the full system, we're seeing upwards to 5x increase in the response times for a lot less money than what we were doing before. And the other thing is the contract that was offered to us to get down to the price that they pitched to us, they stripped away any opportunity to change, enhance, or improve the system over time. Anything we wanted to do was going to be a change order. And so we built into this budget some resources that will be applied to this full time to continuously improve it. Slide. So just looking ahead, now that we're here, the HPC very nicely and our analytic team provided some projects that they're looking forward to using the solution day one. And you can see some examples there. There are many others, but this tool enables us to do a lot of things a lot quicker, not just because the system's faster, but because we've employed all these healthcare methodologies. We have an inpatient grouper, an outpatient grouper, disease staging, risk adjustment, a type of service hierarchy, all built into this therapeutic class grouper. So the statin example I gave, the system's ready to go with all of those. And any user of the system will have access to that. Next slide. And so now we're ready to actually start onboarding some of the other state agencies that have been interested. We had been in talks with the AGO in the past about using the system, Department of Public Health, some preliminary conversations with the connector. We're now in a position that we can begin onboarding some of these folks. And then the other thing is we give extracts of the APCD out to the research community when they propose something to us that meets the requirements. We are now able to include those enhancements I just mentioned in the extracts that we provide to the research community, which will also boost their abilities to use the system. So, and that takes us to our demo. But before I got to the demo, I wanted to acknowledge the absolutely fantastic team that we assembled to put this together. And specifically want to start with Shirley and Ashley. Ashley's going to do the demo in a minute. Ashley represents the analytic departments in our agency on this project, and Shirley, who was actually hired back into CHIA on the first week of this original project in 2019 to be a part of it, became our day-to-day project manager for it. And it was their combination of working well together and the team's dedication that we were able to get here. So I don't know, Shirley and Ashley, if you want to stand up, Shirley, and you'll meet Ashley in a minute. Most of the team is represented here, and you'll have an opportunity to meet when we get through the demo. That's my presentation.
We can't wait to see the demonstration. It is so exciting.
What does the press release look like? For
You
people
think the
who
whole
think,
world will be as excited as we are? Oh, I hope.
for people who think state government can't do stuff.
Yeah.
This is a powerful refutation.
Rarely do you pitch insourcing something, right? I mean, that's, yeah. We were fortunate the design that we have is good. I do want to say we did not rebuild this from scratch. We took the design and used new technology to do it. Yeah.
That's a decision and a risk that you took that.
Yeah.
Really.
It was risky. And
Yeah.
kudos to everybody.
I mean, I want to thank Lauren for supporting. She barely knew us by the time well, she and I did not have a relationship yet, and I pitched dumping the 5-year contract arrangement we had with the vendor, and she was very supportive.
Well, I'll just sort of echo the kudos, because as Mike said, I was new to CHIA. I'm probably the least IT savvy person in this entire office. And so to use Faye's words, it was a leap of faith in many ways. And I thank the team for sort of putting up with my being illiterate and having to use analogies like, how does this system compare to a California closet, or analogies to help me understand the bones and framework of this infrastructure and what we were trying to do. And it was really the dedication, the expertise, critical and creative thinking of the team that gave me the confidence throughout the span of the project. So I'm really, really proud of the team for all of the work that went into this, because when something seems too good to be true, it usually is. But in this case, I think this is gonna return dividends. So really proud and would echo the congratulations and appreciation to the team.
Well, leap of faith in IT is often not enough. So I'm sure it was a lot of rigor, leadership, and true talent. So I think we're very lucky to have this team. Thank you.
I want to point out that the state of New York currently spends $95 million per year on their APCD. It could be that they have a feature we don't have. I'm not aware of it.
Yes.
Makes your bed in the morning.
It's an incredible accomplishment. I don't want to be a Debbie Downer, but this is constantly changing world, and we're going to continue to learn more and more as it's changed. But we're moving up a great base, which we weren't before. Come on. Ashley.
Bear with me while I share my screen in the Zoom meeting and make sure I'm sharing the right one.
No problem.
Okay, so I think as you get the idea from everything that Mike just described, this is an extraordinarily complex system. We have the data that payers submit to us. We have reference data that adds context to the codes that they submit so that we have descriptions and know what's being reported. We have enhancements that CHIA has built. We have enhancements that we've purchased from other vendors. And it all comes together. And there are different ways that analysts can interact with the system. And so we have some folks who are very comfortable with SQL and can write very complex queries. There are people who code in SAS and are very comfortable with that and have been working with that for many years. And then we also have people who are experts in their field and understand the policies, but they're not coders. And we also want them to be able to access the data. In the past, they would have to spend a lot of time working with somebody who knew how to code and coming up with the specifications and have someone pull something for them. Then when they got that, they'd say, oh, I actually wanted to add 2 other columns for that. So could you go back and run that again? And there was a lot of back and forth. And so another access point that we have for this now is our BI tool, and we're using Power BI. And so that's what I'm going to share today. And it's one reason I'm sharing it is just because it's more because it's drag and drop. It is more visual and it's much easier to show than if I was sitting here and writing a lot of code. And I also want to show you just how quickly you can put together something that today I'm going to do something very simple. You can do a lot more with this tool, but just to give you an idea. So wanted to come up with a pretty straightforward use case. So decided to talk about looking at spending and utilization of GLP-1 drugs for weight loss and diabetes, because the HPC has already done a really great job of defining what that is for us, and we knew what therapeutic classes to look at to define those drugs. And so that's what I'm going to walk through today. So what you're seeing right here is the Microsoft Power BI tool. It's very similar in terms of user interface to Excel, and so I think it's an easy entry point for many of our analysts. If I click over here on the data tab, you can see first off, there's a folder with measures that include financial amounts, member counts, claims counts that analysts can use to create a report. I'll show you a little bit more detail on that in a minute. And then everything below that represents a table from the warehouse that's being pulled in that's now accessible to users. And so if you go through, there are 40 some tables that are being pulled in here that are now accessible. And I don't have to know what's in every table. If I want to report on year, I can search for it and it's going to pull up the fields that involve year. Is there any way to move that to the other side? Perfect for those of us in the room. Okay. And so what I have access to here are different, custom groupings for reporting things like age, dates. I can choose if I want to have my report on a monthly basis or a quarter or a year. And if I want that to be a federal fiscal year or a state fiscal year, information on, diagnosis codes so that I don't have to just know what the code number is, but I can search for descriptions. Really a lot of detail that's available to me now when I'm creating a report. The tool has a lot of flexibility to create different kinds of charts. I'm just going to show a bar chart today for simplicity and because we really love our bar charts here at CHIA. But as you can see, you can create tables, you can create all kinds of really complex visualizations, and you can also export the data to other programs. And just to be totally upfront, I have gone ahead and added the filters that I need in my report, just because it would take a little bit of time with the dragging and dropping. I wanted to be efficient with our time here today. But what I've done is I've pre-filtered this to commercially insured members ages 18 to 64 with primary medical and pharmacy coverage who live in Massachusetts for calendar years 2019 to 2024. So that's what we're going to be seeing. Okay, so I'm going to create my GLP-1 report. I want to start with a time component and I'm going to use a year. So I'm going to drop that onto my x-axis. Once I have data, it will populate in there. And then for measures, today I'm gonna report on the total paid amount, which adds up the amount that the health plans paid and what the members paid in out-of-pocket spending. So I'm gonna use a sum. I also have other options here. I could do a per member per month average calculation. I could do a straight average across the claim lines. I could report on max or minimum total paid amount during the year. But I think for the summary level, I'm just going to look at all of the spending over the year for this APCD population. And so I'll just drop this down so we can see a little more detail. So this is my basic graph. I've got my spending by year. I think I want a little bit more detail on that. I'm going to pull in the therapeutic class so that I know a little bit more about the types of drugs that we're driving the spending in each year. So again, that's running a query out to the warehouse and bringing it back. So now I can see, so these are kind of small right now, but I can see the blue are dulaglutides. The darker blue is liraglutide, the orange are semaglutides, and the purples are tirzepatides. I can see that's really growing over the last 2 years. And then I have a lot of options here. I can add totals in here, and maybe I'll make those a bit bigger so that we can all see them. Increase the font sizes on a few of these. And it defaulted to billions, but I want it to be in millions. But you can see it really doesn't take a lot of time to create a really simple report and to iterate on it as we go. And if I wanted to, I could certainly say, you know what, I've been working on this. I actually wanted that to be a table instead. So that's going to rerun that. Maybe I want to reorganize it. And you know what, I need a little more detail on this. I've been asked to provide brand names. So I'm going to go in, pull in the product name here, and expand that out. And again, it's going to run that query. And now I have my spending by product name. And so it was very fast to create that report. I can export it to Excel. I can save it as a PDF. I can share it as I want. And so I hope that gives an idea. I have a few other just prepared graphics just to show you again. You can look at this by total spending. We can look at it by number of prescriptions. Here we've created a just a toggle so that you can look within a therapeutic class, what brands had the most total spending and the most volume in each year. So within this tirzepatide class, we see how Mounjaro on the red and Zepbound in the blue changed over time. Here on the liraglutides, we can see, oh, look, a generic came to the market right at the end of 2024. That's something I'm going to want to look at as time goes on. And then the last graphic I have here is just looking at the percent of commercially insured adults who had at least one GLP-1 prescription in a year. And so this is going out to our member eligibility data, seeing how many people were in that population, and then how many people had prescriptions and pulling it all together. So I know this was like lightning fast, but I hope that gives you just a sense of what we can do and how quickly an analyst can pull together some of this information.
For those of us who remember the old days, there's no way you'd be sitting there writing things down. It's amazing. It's great. Thank you.
This is the 100% sample? Like this is
everybody, yes.
I've opened, like I've used the ABCD data before and like opening a 10% of the member eligibility file on the NBER servers.
She's excited.
I'm not the technology person, but moving to the cloud has been really great in terms of the performance that we're seeing.
We pay by the query, and that was about $2 that it cost us in Snowflake costs.
And so who, and I think you've talked about this, but now that I've seen it, it's like, oh, anybody could do this. Who actually, can any of us go home and just start playing around, or is it their licenses or theirs? Like, I don't have a sense.
Yeah, so first of all, you need to have an account that allows you privileges to access the APCD. You need to be, tapped into CHIA's network, either over VPN or through a virtual desktop. So it's certainly not something that just anybody could do. But I think, anybody who has, sort of the access.
We created it principally for our sister agencies and ourselves, but that we have an external interface for anyone that's not in our network, which is, we are the only ones in our network. So HPC uses our Azure Virtual Desktop to log in. They can go to a web browser and log in right over a web browser to get into these tools. We are prepared to expand the access to folks. We want to do it very measured though, train the people. It's still something that you could use without, if somebody were to try to do something overly complex without understanding it, they could, use up a lot of resources. And so we want to train people on methods as they get deployed, but we are in a position to start doing that.
Are you satisfied with the quality, the accuracy, and the detail of the information provided by Medicare Advantage plans and by Medicaid managed care plans?
That's a complicated question. There's a lot of different uses that you could use that data for, and I think each time we have to look at the data quality for the intended purpose that that you're going to use it for. It is claims data that comes right out of the adjudication engine of all the payers and Mass Health. So it is going to be raw. And I worked at a plan for years, and we shoehorned complicated new products into adjudication systems that weren't built for those products. When tiered networking came out, our 20-year-old adjudication system was not built for tiered networking, so we rammed it into empty fields. And so that manifests itself when it comes to CHIA. We are getting data from about 60 different claims adjudication systems. So you'll always have to really get to know the data for its fit for purpose before you do a study.
I would like to end the meeting early. So for those that have to scoot out at 4 o'clock, you will have a chance to get a snack and also thank people in person. So do I hear a motion to adjourn? Second.
We need to vote.
The word snack.
Exactly.
Ready to bet?
Yes, we have refreshments and cake and snacks in the back. So
We were-
will stick around.
We knew Snowflake was going to really work well for us, but it was so much better than
Project song.
most